Hi, good afternoon. Again, I'm Tony Puente, broadcasting the third of five, I should say, of CPT webinars on the current procedural terminology. And our focus today is going to be on health psychology, but it's really much more complicated than just health psychology. It's going to be about the whole idea of making psychology its primary focus, not just on mental health, but on the entire healthcare spectrum. So today we're going to do a series of slides. Some are old slides that you've seen before, including the disclaimer. And then some are very new slides that I've just come up with, including a new case that just came out involving fraud and abuse that will be towards the end. So this time, I think we've actually fixed the certificate, which is at the end of the presentation, and we have the capacity to be able to deal with questions and answers as we go on. So with that, I'm going to give you a better picture than my face, and that is a series of slides. So we'll see you in a few minutes. Okay. All right. Well, again, thank you for joining us for this third of the five CPT webinars on coding, documenting, billing, and auditing psychological services. As I mentioned earlier a few minutes ago, today's presentation is on health psychology. As always, I do my best to give you the latest and the greatest, but there is no certainty to the information I provide. So we hope that you consider this as an aspirational presentation rather than the most definitive one. I can tell you that as far as I know, we're on target, but sometimes there are some variations from the theme, especially between what I say at the federal level and what occurs at the local coverage determination or LCD level. As always, I want to acknowledge many organizations, including North Carolina Psychological Association, APA, as well as the American Medical Association, specifically the CPT staff. Many groups have been very supportive, and you see them there. And also, as always, I want to emphasize the importance of how many people have been very supportive of this. I do want to emphasize the work of Randy Phelps, who is the APA staff person in charge of the CPT system, and our representative on the CPT panel, Neil Pliskin, and our longtime colleague and great mentor in all of this, Dr. Jim Georgialakis. There is really no support, at least economic, for this kind of activity, including today's presentation. What is provided by AMA is the continuing sending me to presentations and attending the CPT meetings. As I mentioned many times before, this all started at my State Psychological Association in 1988 and continues today with my work on the American Medical Association's current procedure terminology editorial panel. I served as an advisor for 15 years from the AMA to, from the APA to the AMA. And the last few years, I've been one of 17 members of the AMA CPT voting panel. A great opportunity, responsibility, and honor. So, as always, too, I have to emphasize that despite the shortcomings of APA Ethics Code, which many of you are familiar with because of recent difficulties with it, it still is our best aspiration. In addition to that, of course, the HIPAA, state, province license regulations, professional standards, and I should emphasize, very important, that the contractual agreements that you have with third parties continue being what defines your relationship with the insurance company. All right, so let's begin by jumping into a very interesting issue, and that is, what is Medicare's definition of a physician? As you may know, physician describes any doctor-level provider in healthcare, including medicine, dental medicine, optometry, chiropractic, but not psychology. And by the way, that is the Social Security Act, which was passed in 1989. Medicare's definition of physician, interestingly, requires oversight by physicians in certain situations, including inpatient psychiatric hospital, as well as general hospital outpatient, but not in other situations, which is particularly curious because very often the service is provided not by the physicians, but by psychologists. And to put it in the simplest terms possible, psychologist is basically what the state says you are. There's really no big definition of it beyond what the state defines, because in many respects, that's the bottom line, and for that matter, provinces as well. Let me move on to what really, technically speaking, the definition of a psychologist is. According to the Social Security Act of 1989, we are not defined as a physician. And according to many individuals, including Nick Cummings and Pat DeLeon, both who were there during that particular time, we've had two great opportunities to be involved with the Medicare program. One was an inception 1964, which we missed out because of I don't know, let's just call it oversight. And then again in 1989 by some APA staff who believed that maybe at that point we were not physicians. In fact, we're not physicians, but because we're not physicians, we're defined by Medicare as technicians. There are really two kinds of individuals: people who do cognitive work and people who do the technical work under the supervision of those who do the cognitive work. So for all practical purposes, we have physicians and technicians. According to us, we think of ourselves as, if you will, psychologists, but according to them, we're really technicians. A major, major problem in our history in terms of advocacy. However, according to the CPT system, is something that I've worked very hard and been very supported by the AMA staff. We are considered a QHP, qualified health provider. Essentially, that means you are an independently licensed doctoral level provider that can provide, according to state licensure, a provision of healthcare services to individuals in an effort to obtain some remediation of the problems. Now, technically speaking, what is a psychologist according to CMS? You have to have a license or certification, as in the case of, for example, other territories, a provider number. You have to have a doctorate degree, and you have to come from an accredited school. You must be listed in some source, like the APA directory, a national register, or be certified or board certified, for example, ABAP, or one of the other associations as well. Now, this is nothing new, but I do want to make a point, and that is what I talk about this evening with you, or if you're in a different time zone earlier in the day, is basically what I consider to be aspirational at the federal level. It is something that's scientifically, politically, in many ways diplomatically vetted. Having said that, if you are part of a provider network, for example, with Magellan, Aetna, etc., you are part of a contractual agreement with a local coverage determination, which is basically a refinement of national coverage, much more restrictive. I say typically, but almost always much more restrictive. And oddly enough, the LCD is almost never announced or advertised, but conceivably available in different locations, primarily websites. It may appear unusual and non-reflective of national standards. And I might add that in some cases, actually, it's developed by individuals who are non-psychologists and maybe in some cases even non-physicians. A wonderful example is one that was shared with me recently, and that is the Wisconsin Physician Service Insurance Corporation, often referred to as WPS, and their testing LCD, which is somewhat similar to what we would hope for, but not necessarily entirely what we expect or would wish for. The information discussed in the next few slides, and for that matter, available in the large CPT slide set, which is found below psychologycoding.com is material that is copyrighted by the American Medical Association, and the manuals may be ordered from the AMA at the number that's listed, or alternatively, you may look it up in their website, ama-assn.org. All right, to get to the business of our discussions this afternoon, we are going to focus on, first of all, explaining to you a very basic model system, which I've shared with you, or you may have heard before in the past, and that is that there are three areas in the CPT system. There are about 8,500 CPT codes. In psychology, we have access to about 50 or 60 of them, maybe a few more, and they are generally subdivided into the psychiatric, neurological, health. Historically, we have found ourselves working within psychiatric areas, but because of time and hopefully the expansion of services available to our clients, we've expanded into the neurological and health realm. So today we're going to be focusing on one of these silos. The first silo is the silo that we discussed our last presentation in I guess about 30 days ago, and that's a psychiatric one, which you can see works off the DSM. DSM-5, we have an interview, testing, and therapy code. And then on the far right-hand column, we're going to focus today on health psychology. ICD, the interview code is 5.0, testing code is 5.0, any type of intervention or therapy is 5.2. So we have three silos. Our focus today is going to be on the third silo, which for all practical purposes represents approximately 95% of the healthcare dollar, which in turn represents approximately 16 to 17% of the gross domestic product. So this is a large chunk of our activities or potential activities, I should say, and it's probably in many ways our new frontier. So let's focus on this in great detail. First of all, I want to emphasize that we must choose a code that best describes the service, match the interview with the testing and the intervention with the diagnosis. Do not mix codes. For example, it's probably not a wise idea to do a 90791 with a 96150. Unless there's a specific rationale or reason for that. So, for example, you will refer the patient for depression, and it turns out that they have a difficulty with chronic pain. That is reasonable. But all things being equal, do not cross silos if at all possible. Stay within one silos, which is not to necessarily suggest that you may not go from one silo to the other as time evolves, and I'll share with you how that is actually done. There are several things that I want to mention that are sort of not so important, but you should be aware of, and that is the issue of CPT modifiers. You see that some of the different modifiers, for example, 22 and 59, consider using this in case of unusual circumstances. So, for example, if you have a prolonged service, maybe H&B, health and behavior codes, that take a little longer than usual, you may want to consider a 22. If you do, for example, psychotherapy and health and behavior, which technically speaking you shouldn't do, then make sure that you add the modifier 59. Some folks ask me, how do you add a modifier? Well, you add the basic CPT code, and then you put a dash, and then the modifier as applicable. This is intended to tell the insurance company that this is not your typical activity, and you want to make sure that they're aware of it so they don't simply basically audit your claim out of the system. So our focus now is going to be in health and behavior. Let's go into some serious discussions of what that is all about. First of all, this was put together back in the early 2000s on direction of Randy Phelps and the Interprofessional Healthcare Group that involves several groups or divisions like 22, 38, 40, and so forth. These individuals that are part of the APA and are also very involved with understanding, engaging, and doing something about the healthcare crisis that we find ourselves in. They've been very much involved, looking at the future, and this is essentially comes out of a work group that was chaired by Randy and others approximately 15 years ago. This is very, very different. Let me explain why. First of all, this does not involve the DSM. This involves the ICD. It's about medical diagnosis, not psychiatric diagnosis. Very important point. One of our great colleagues, Daniel Bruns, has put together a super slide set on bariatric surgery and the use of H&B codes. He talks about this in that particular presentation, although it does say at one point that you can use psychiatric diagnosis. I'll explain when and how, but the primary diagnosis has to be medical, not psychiatric. This is a major issue. So we're not dealing with emotional problems. We're dealing with medical problems. Point 2, this is in 15-minute increments. It is not in 30, 45, or 60-minute increments. As you know from some of the other discussions that we've had, most interventions, and for that matter, diagnosis, are 60 minutes or thereabouts. But in this case, it's 15-minute increments. I did not say it on this slide, but I want to make sure that you hear this, and that is that the increments are in multiple units. So if you put down on the insurance form 1 unit, you'll get reimbursed for 15 minutes. Now, another question you might have is, how long is 15 minutes? Well, it has to be at least 7.5 minutes for a 15-minute increment to occur. And then, of course, you add 7.5 minutes to the first 15, and then you're ready to go for 2 units. And finally, we have both assessment and intervention. But just to summarize, this system is for medical and not psychiatric. It's 15 minutes, and it's often in multiple units. So what's the rationale? Well, as you can see, first, it's about acute or chronic health illness, although as you'll see later on in our slide set, we do have quite a bit of information about chronic health illness, and that will be the future of healthcare. You must use an ICD diagnosis, International Classification of Diseases, and for right now, for today, and for the next few days, you can use, or you should use ICD-9. A question people sometimes ask is, should I be the first one to do an ICD diagnosis of a medical condition? Well, of course, that's defined by state law, but for all practical purposes, my suggestion is that you don't do that. Have someone else with a medical degree or related that would actually provide the initial diagnosis, and you can take it from there. These codes do not apply and do not necessarily interface with psychiatric illnesses. I might point out that in some of the edit systems, like the McKesson's, there is an edit system that basically, or a glitch, if you will, that prevents you from billing a psychiatric code or a psychiatric intervention, like psychotherapy, with one of the H&B codes. However, you could theoretically end up dealing with both, and I'll emphasize how to do that in a few minutes. All right, so let's get to the meat of it. Now we're 20 minutes into our presentation, and this is basically the core of our discussions. 96150, health and behavior assessment, 15 minutes, and face-to-face initial assessment. Let's take care of this one in much greater detail. First of all, you see that it's EG, health focus, clinical interview, behavioral observation, psychophysiological monitoring, and health-oriented questionnaires. This is anything whatsoever, clinical, psychometric, or behavioral, that allows information gathering about the client in question. It doesn't matter how you do it. What it matters is that you gather information regarding the behavior of the health situation. For example, how does somebody deal with chronic pain? How does a child with type 1 diabetes deal with compliance? That's what it's all about. Again, 15-minute increments. Face to face. I appreciate that this is a major problem, and I take full responsibility for the fact that when we first introduced this, or I should say I introduced it to the AMA CPT panel back about 15 years ago, I was asked the question, is this face-to-face only? And the answer was yes, realizing that this was entirely a strategic, diplomatic decision to make sure that we had these codes. Keep in mind, folks, this is the first time that the entire medical community allowed us to deal with medical problems. And in essence, this was a diplomatic decision, spur on the moment, and one that needs to be revisited because there's so much more work to health and behavior than just face-to-face. If you repeat the reassessment, for example, if you go back on Tuesday after doing an initial evaluation on Monday, you do not use 150. The repeat examination is 151. Now, the question that you might have is 151 when there is a new disorder or when you're reassessing the existing disorder? So, for example, if I'm dealing with chronic pain on Monday, that's 150. If I go on Tuesday, that's 151. If on Monday I do chronic pain, that's 150. If Tuesday I'm dealing with compliance issues with regards to diabetes, that's, again, a 150. So each are disease specific rather than specific to the date. Now, what is an H&B assessment? As I mentioned to you, and you can read for yourself on this slide, it is anything that you can do to gather information. The focus is on biopsychosocial rather than mental health factors. So what can you do? An interview, an observation, monitoring with a GSR, something of that nature, respiration, health-oriented questionnaires like the Milan. It doesn't matter. Whatever you can do to obtain information about the client and the relationship the client has to the disorder in question. Health and behavior intervention. We have 4 here. We have codes 152, 153, 154, and 155. Heads up, it's really rare to have 155 be reimbursed. Family without the patient present, typically not reimbursed. What's most common is 152, 153, and 154. And I want to emphasize on 153 that you need at least 2 patients, and it could be up to about 10 or so members. And 154 involves the execution of intervention together with the family. Examples include cognitive, behavioral, social, psychophysiological. You could do biofeedback, although there is a specific biofeedback code that sadly enough is not very frequently reimbursed. You could do CBT to understand how to deal with medicines, or for example, you could do relaxation training to try and decrease or the experience of the pain, or even some social interventions to try and develop social skills, such as how to best deal with a difficult physician who doesn't listen to you. Now, a word to those who work in institutions involving CORF, and that is, this is the only code, that is 152, that can be used for both assessment and intervention. So it's important that you appreciate that you cannot use other codes, only this code. A question that often arises is how many units or hours can I complete? Now, this is not well defined, especially because some of the LCDs are not clearly outlined for us. But the initial assessment, I would say 1 to 2 hours, or approximately 4 to 8 units, and I can't be certain of that. A reassessment, maybe 4 to 6 units. Group, maybe 8 units. And the total interventions could be anywhere from 24 to 48. So the pattern that you see is maybe 1 or 2 hours for the evaluation and several hours for the intervention. But again, This varies according to provider and, more importantly, according to the contractual arrangement that you have. So this is basically the concept of dealing with medical issues: 150, 151 for the interview and assessment, and 152, 53, and otherwise for the intervention. Now, hold on a second. Let me add a new caveat. For those of you that have this opportunity, consider this. Telehealth now includes all health and behavior codes, which is interesting because that's not the case with the testing codes. That is neuropsychological testing codes and so forth. If you do decide to do this, keep in mind that the patient has to be remote and it has to be a live video, not audio feed. And in addition to that, there could be a facility fee, especially if you're the one that initiates it out of an institution. Clinical psychologists are now included. So one more time, audio and video. You must have a site that has a professional shortage outside the metropolitan area. You can't necessarily just do it down the street. And it could originate from an office, hospital, clinic. And for all practical purposes, the telehealth means that it must be assuming the concept of face-to-face activities. Now, the question that's still not clearly in my mind: could this be a telemonitoring, teleconsultation, e-contact, or kiosk? My assessment that the typical activity that you would be doing would be teleconsultation for diagnostic work and possibly telemonitoring for chronic conditions. That's still not well defined. And here's some resources: the APA's Guide to the Practice of Telepsychology. It's a well vetted out and well written, and I encourage you to consider getting a hold of that. Now, what about the idea that you could engage in team conference activity? And there is a code that I'm going to share with you. It's a code that's been around for a few years. I might point out, not well reimbursed or often reimbursed, but this code allows for the billing professional work in interdisciplinary team activities, including diagnostic and rehabilitative. Team conference a time of less than 30 minutes are not reported. So we're talking about a code that requires you to be involved with the activity for at least 30 minutes. Otherwise, it's incomplete. Okay. All right, let's continue with what the codes are. That's 99366 and 99368. So for example, if you have the patient there, theoretically, it would be 66. If you do not have the patient, you're discussing the case, it would be a 68. You have to have 3 different specialties, and you have to present the findings, recommend the treatment, and formulate integrative care. Integrative care. It's a word that I'm going to be using a lot in the next half hour. The coding rules, as you can see, are very complicated, but only one individual can report. In addition to that, it could be that if you are contractually associated with a facility, you cannot bill the team code. And it's not used for record keeping, and report generation is not used to be reimbursed. And you have to report the time as always. This is a very new code, exciting and potentially problematic. It's called a Complex Chronic Care Coordination of Services. Basically, it's hot off the press. But in case you've seen this or not seen this before, note that the number is a new set of numbers, 99. That's in the evaluation and management world. And that code means it's not face-to-face by a qualified health professional, and it's a coordination of care. One more time, at least 31 minutes of activity. If you have the patient there, that's 8-8. So think of this as a slight interpretation or difference between the team conference codes we just looked at. You have the capacity to basically do this if you're coordinating a care, but you don't have to have all the other requirements. So if you have multiple disciplines together, use the team code. If you're doing this essentially by yourself, you use these codes. Now, How does it look like? If the service is 31 to 74 minutes, you use 99487. And if you're going to add any more, you do 88. 75 to 104, again, 99487 or 88, and then you keep on going. So essentially, the base code, something that I've talked about, the base code is one of these, 87 or 88, depending if the client is there or not. And then from there, you just simply do it in multipliers. You can't go much more than 105 minutes. I believe this complex chronic care coordination services is probably the beginning of integrated care for medicine. What I'm not entirely sure if this is going to be the beginning of integrated care for non-medical providers, such as psychologists. This poses some challenges because, as I mentioned not only before, but also many times prior to this presentation, E&M is the holy grail of physicians. So many insurance companies may not give you access to these codes, but this is where we're headed. Now, let me give you options that maybe you hadn't thought about. Here's a couple. Have you thought about health behavior screening? For example, how about G0396, where you can check out for alcohol, substance abuse. The G codes, the health behavior screening, may be something you can consider. However, all things being equal, including the tobacco cessation codes, these are E&M codes, preventative codes, and not frequently reimbursed. But consider this. All things being equal, again, which they're not, H&B codes are most likely to be the ones that will be allowed. All right, what about preventative codes like 99401? Consider them, but again, they're aspirational and rarely realized. If you go down that path, consider using a 33 modifier, especially if you're doing such things as health, diet counseling, obesity counseling, tobacco cessation counseling, etc. These codes may be added, that is the 33 modifier, may be added to the H&B codes to be able to be reimbursed at a higher level and give you a possibly higher number of units as well. Here are some examples: health, diet counseling, obesity screening, and so forth, so on. Even though many of us do not have access to evaluation and management code, this is the basic foundation for almost all healthcare. This is what you and I might call follow-up. Created by 1982 and together with CMS has been the primary activity of almost all physicians today. It's not specialty specific, it's not necessarily diagnostic, and it's almost all cognitive work. So be on the lookout. We may go there sooner or later. Right now, we don't have access to most evaluation and management activity, but this is the foundation, the backbone for almost all of healthcare, especially outpatient. A few words about diagnosing. And for those of you that are aware, I've put together an ICD-10 presentation that's been distributed to the state psychological associations. And if you haven't had the opportunity, contact them because we've distributed this essentially free of charge to encourage people to begin to be thinking about ICD rather than the DSM. Now, a word or two real quickly before I go and talk about the ICD. I want to emphasize that the billing diagnosis is what is the referral question, whereas the clinical diagnosis is what you ended up with. You bill what you go after. You do not bill what you find. Do not mix psychiatric and non-psychiatric DXs, and use the primary DX that appears to be the most critical one. Now, let's shift our focus for the next few moments regarding ICD. Here we are on the verge of September, and 2 months, we will move to ICD-10 clinical modification. There is no likelihood that will be changed. And in fact, the only thing that needs to be changed is the slide that says October 21. It is not October 21, it's October 1. And I have not heard anything through the grapevine that tells us that we have any grace period. At midnight things will just turn into a major pumpkin if you are doing DSM. All right, so how does this work? Well, for those of us that are old enough, you might think that ICD-10 looks like a Ouija board. It really isn't that hard. It does look a little different. ODN90ZZ, whoa, what's that all about? The first 1 to 3 are the basic category, and that's what you need to focus on. And in fact, I believe that most of the codes that will be the first to be introduced will be very simple ones. 4 to 6 are much more intense, etiology, site severity. That may be important. This is a critical issue. That may be important for 2 groups of psychologists, health psychologists and neuropsychologists. I have a hunch that if you do mental health, you should be able to get away with the basic categories. If you do anything beyond that, you may have to have more. We don't know that. It's too early to make a clear diagnosis, so to speak, but I got a hunch that as time goes on, those of us in health psychology will be doing more than 3 categories. So you will do alpha numeric and then alphanumeric, and then we'll get into the real meat of the matter. What about DSM-4 and for that matter 5 and ICD-9? What will happen? As far as I can tell, they'll simply wither away. There will be no future for ICD-9, even though there's a crosswalk, and DSM-5 will obviously be replaced by ICD-10. Now, I want you to understand this. This is a critical point, one that my postdoctoral fellows who helped me put together the ICD-10 presentation have suggested on a number of occasions. DSM is part of the ICD. ICD is the diagnostic system. DSM is essentially not a diagnostic system. It is a descriptive system. So it adds information to the diagnostic code that comes out of ICD. DSM is part of ICD. Regardless, if you do health and behavior, you should be working in the ICD-9 world, and in about 2 months, you'll be working in the ICD-10 world. Now, some interesting points, and I'll define this more as time goes on. First of all, the ICD is not really a system of nomenclature of diseases. It's actually a system of nomenclature of signs, symptoms. Very new for many of us. In the ICD system, you have to diagnose everything that you found and include everything that others have found. So for those of you who work in the health psychology world, you know that many of us have to deal with multiple diagnoses with physicians. You have to do the same. A few words about medical necessity. This is not scientific necessity. It's about a formulary. And that formulary is basically does not allow screening or regularly scheduled visits. Medical necessity is services which are reasonable and necessary for the diagnosis and treatment of illness or injury to improve the functioning of a malformed body member. So what's the bottom line? Existence of evidence for therapeutic decision making, or to put it in the simplest terms possible, will what you have done make a difference? Now, let's talk for a few moments about report. What's a report? Essentially is what you document to define what you have done. The basic information is found in this slide. Nothing really complicated. The date, the time. Oh, by the way, total time is passé. It's actual time. Impression, diagnosis, and plan for care disposition. One of the things that I want to emphasize a little bit is, especially since we're dealing with illnesses in this particular section, what's an illness? Location is a critical thing. I'm going to spend a few minutes on this. Documentation for H&B requires that you have to show evidence of coordination of care with the patient's primary medical care provider or other providers for the medical management of the disorder. You cannot work an H&B alone. You have to work with other healthcare providers. So an assessment includes onset and history of initial diagnosis, clear rationale why this is required, assessment outcome including mental status and ability to understand and respond meaningfully to the behavioral or cognitive goals that you're pursuing or processes, and what are the measurable goals. I'll talk about measurable goals in a few minutes. In terms of intervention, there must be evidence that the patient has capacity to understand. There's clearly defined psychological intervention, measurable goals, documentation is expected to improve compliance or, for that matter, the disease process. There must be a response and a rationale for the frequency and duration of service. Each CPT code should generate a separate report. So if you work on Monday to do an evaluation, Monday generates one report. If Tuesday you do the intervention, another one. Alternatively, one lengthy report with very clear titles is necessary. Now let me take a moment to just go down a different path. This is something that just came across my desk and I want to share with you. One of our own in the Eastern District of Louisiana has been indicted for conspiracy to commit healthcare fraud. And that individual billed $12 million, actually I shouldn't say billed, collected $12 million between 2009 and 2015. They provided psychological testing and therapy that was, quote, not medically necessary and, quote, sometimes not provided. In this particular case, they made false entries resulting in claims amounting to 84 units of 96101 on 0911 and made false entries about another individual and made false claims dealing with 68 units of 101. In essence, this is what we call an outlier. The reason I bring this case up is because outliers is how they identify you. So if you're doing health and behavior and you're doing, say, for example, 30 units of consultation, that is assessment, you're going to be considered an outlier. Just because they reimburse you does not necessarily mean that they will not do a post-payment audit. Now, let's go and talk about some of the future things that you should be concerned about. State will create exchanges and they will provide information to the individuals as who is and who is not eligible. This is our new battleground. Washington has been replaced with state capitals. And what will happen is, as in my community, you'll end up with an accountable care organization. In our community is the largest medical group that I used to be part of, and the hospital, which I used to be on the staff as well. And essentially it's going to expand Medicaid eligibility. And I believe that this will be a major issue. Approximately 15% have signed up, and it's expected to have a tremendous savings of approximately $1 billion. Now, this is an important point, okay? It has to be transparent and disclosure. There's limited to external and external costs and so forth, so on. However, you need to understand that all kinds of patients will be there, and those individuals will theoretically be your livelihood. The way I see these health insurance exchanges, and for that matter, ACOs, is that this will be an expanded Medicaid program at best, or Medicare Light as well. This is about increasing number of clients and decreasing costs. How is this going to happen? Prevention and integrative care. Prevention and integrative care. Healthcare dollars will have to go down. We cannot be going where we're headed, which is about 20% of the gross domestic product. The assumption is that preventing individuals from getting sick and integrating care will be the way to go. If you look at the ACA, Affordable Care Act, they note that 75% of of individuals have chronic illnesses. And interestingly, that 50% of mental health care is done by PCP. There are lots of psychologists, and we are now in a position to become a great integrative care leader or pioneer. We will be the ones that involve comprehensive assessment, will place individuals in healthcare homes or be part of a healthcare home. There'll be comprehensive intervention, and you will share records. You will share the records. And the consumer begins at the very beginning. One thing that I want to emphasize too, this could be geographic, for example, it could be the same building, or it could be virtual. By that I mean electronic, where you share their medical record across multiple sites. This is the view that I have for the future. And I want to emphasize the last line, that the patient will be in a healthcare home, and it will be most likely empirically based. And in addition, that the approach will be totally personalized. So we have a different pattern. Now, something I haven't talked about a ton, but I want to say a few words about. I am suspecting that whether it's a healthcare change or Affordable Care Act organization, that the services will be bundled. That is, that a patient will be sold at, say, $200 a month to a large affordable care organization, and they will take care of that patient for the entire health of that person, whether it's a gallbladder, whether it's chronic pain, it doesn't matter. It will be given to a large group. Then that group will have to define what to do with those individuals. The way I conceive it is that individuals will be part of a healthcare home that will be handled by a physician, primarily associated with an ACA, that will be provided a bundled amount of money. And you will be part of that home as a way to provide healthcare services. We're moving in a basic tsunami where performance is going to be the bottom line. Uniformity, transparency, documentation are going to be the day-to-day words that basically guide our lives in healthcare. However, the two big ones will be performance, that is, not that you do something, but what happens as a function of you doing something, and that things will go into the integrative mode. So I predict that if you do traditional healthcare, or for that matter, mental health, that your work will be unsustainable by the year 2020. You will experience yearly reductions about 1 to 5%, most likely 2% will be the standard for the next 5 years. And then new paradigms will emerge. Let me tell you some. Boutique services, when you bring something to the equation that no one has. For example, a Spanish-speaking health psychologist. Prevention. We have historically dealt with illness. How about the worried well, looking for the future to make sure that people don't get sick? Integrative and multidisciplinary healthcare will be the bottom line. You will have to be part of a larger group. And that group is either geographic or virtual. And I suspect they'll be interfaced with other industries, sports, industry, and for that matter, the forensic profession. Now, there are several sample forms that I've found and I've shared with you in the Psychology Coding webpage, and you see some of them here. And here is a certificate of completion. We guarantee and double your money back. If the certificate does not work, we will hand deliver one to you. There are a bunch of resources. These are great resources. If you have problems sleeping, I encourage you to take a look at them all. And of course, check out the AMA website. In addition to that, the APA website. If you haven't given, give to either the APA-PO or the Association for the Advancement of Psychology. And finally, here's my contact information. So you're welcome to write me if you have any questions or concerns, stories, and of course, always jokes. So with that, we will go to your Q&A. Okay. In order to ask me questions, please click on the grid next to the question mark at the top right-hand corner of your video screen. And then, after you do that, click on the blue Q&A. So let's see if you have any questions at this point. Okay, so at this point, we do not have any questions so far. All right, so I'll ask a question. I'll ask two questions to get us rolling. First question is, what about the H&B codes? I'm not familiar with them. I don't use them. Consider using H&B as an addendum to the work that you've done. I want to emphasize, and I've said this before, I believe that the future of psychology will not just be in mental health. I hope, I trust, and I'm working personally to making sure that there is a future for the mental health. We are the leaders in mental health. But in addition to that, I want to make sure that you think that the future of healthcare really rides on the backs of psychology. We are the best suited to provide integrative care. So how do you bill when testing and report writing occur on separate days? This, unlike the standard psychology and neuropsychology issues, this is not something you need to worry about. You simply provide the information according to the date of service. So if I do testing on Monday and I do report writing on Tuesday, theoretically, you would have to provide, number one, information on Monday. Keep in mind, unlike the psychological testing, this is basically face-to-face. So if you do the report on Tuesday, you have to basically bill as if it was Monday. You do not get paid for writing the report. You only get paid for seeing the client. So apologies for the long-winded and complicated explanation, but you only get billed, you can only bill for face-to-face time, unlike psychological testing, which allows you to bill for face-to-face and non-face-to-face time. Rosemarie, thanks for the question. I hope we've answered your query. All right, any other questions? Okay, let me ask another question. How do I get involved with an affordable care organization? I really want to do healthcare. I want to do both mental health and, if you will, behavioral health for healthcare, like the H&B codes as we've discussed this afternoon. Well, you have to be careful because you could be left out. For example, in my community, there's two ways. One is to join Wilmington Health Associates, and the other one is to join New Hanover Regional Medical Center. What if you just happen to be an independent practitioner? Well, at this point, there is no answer. So you have to be careful. You probably have 1 to 2 years to either join one of those groups or have a contractual arrangement that could be electronic. But at this particular juncture, it looks like you will have to be part of a group or at least be a consultant to that group. I don't know what will happen if you are left out, but at this juncture, it's too early to tell. Most individuals in healthcare are not part of an ACO, but I suspect that they will. The work of Susan and Rochester, Susan Daniels in Rochester, has been instrumental in making sure that we're integrated with primary care. That's important. Having said that, that's not going to be sufficient. We need to be integrated with primary care and all of healthcare. But it's obvious that that seems like an initial and important first step. All right, I do not see any other questions at this particular juncture. So by all means, please feel free to send me your questions by email at puente@uncw.edu. Thanks so much for joining me again. And I look forward to seeing you next month, where we'll do basically neuropsychological testing and psychological testing. Thanks a lot, and have a good evening. Bye-bye.